I'd like to thank the members of the National Academy of Science for inviting me to give this talk, and I have no financial disclosures to report to you. I am very thrilled to be able to talk about the ethical principles that apply to this workshop today. There are lots of ethical principles that have been given by great ethicists. Al Johnson, who really started clinical ethics, Joseph Fletcher, and of course, Beecham and Childress with their 4 basic principles. But interestingly, I'm going to argue that only 3 principles apply to the main ethical issues about getting evidence for older adults with cancer. Other ethical principles could come up, obviously in specific circumstances, but this morning we're going to discuss non-maleficence, autonomy, and justice. First, non-maleficence, ancient principle, bedrock of medicine, started with Hippocrates in 500 BC. First, do no harm. And what if a physician has no evidence about the treatment? How does he or she decide? Well, obviously, in the history of medicine, it's been best clinical judgment. But if you review the literature on cancer in the elderly, you hear words like whim, arbitrarily, assumption, observation, conjecture, and even bias. It is extremely difficult to do no harm when you lack evidence, because it impedes the ability of oncologists to deliver optimal treatment to older patients because they have to extrapolate the data from younger, and this places older adults at serious risk of negative consequences. Second principle, patient autonomy. This is the right of adults to make informed decisions about their own medical care. We're all familiar with this principle. And interestingly, this is not a Hippocratic principle. Matter of fact, Hippocrates went to great length to inform the physicians of the day that they should conceal what they're doing from the patients, turn their attention away from what's being done, and reveal nothing to them about their future or present condition. And actually, autonomy, there were some court rulings in the early 1900s, but really didn't gain traction until the civil rights movement. So, in order to have autonomy, a patient has to have capacity, which means that they understand the benefit and risks and alternatives. They're able to use that and assess those with their own values, and then they have to both make and express a choice. Now, what's interesting is it's wrong to assume that an individual lacks capacity just due to age. And none of these on the screen show you that the person doesn't have capacity. They can be unable to perform tasks of daily living. They can have physical disabilities, be frail. They still could have the mental capacity to make an autonomous decision. They could be confused like medical jargon, like most of us. They could want a medically counterindicated treatment or rely even heavily on family members' input. And still, that doesn't mean that they lack capacity. Another assumption that threatens autonomy is that the assumption that, well, older patients just don't want to participate in clinical trials. I love this SWOG study that was published in 2012. This SWOG study actually followed 909 patients from diagnosis. 364 were eligible for a clinical trial. Obviously, most of them were less than 65. But of those who consented, the 142, there was no difference by age whether or not they consented. The only difference they discovered was that older patients were more concerned about side effects. There are factors that might impair autonomy that have to be addressed in an older person, maybe impaired hearing or sight, loss of independence, reliance on family. Maybe they ask for less information, expect the doctor to make the decision, or they might be a little reluctant to ask for clarification. But all of these can be addressed. Third principle, justice. Healthcare professionals have a duty to act with fairness, giving every individual his or her due. Justice is an old principle. It's in Plato's Republic. Aristotle did a nice job of defining it in the Nicomachean Ethics. It's been around forever. But justice is thwarted if there is negative discrimination based on age. Now, we have to be a little careful with this ageism, discrimination by age, because there are different types. There is negative ageism, which are judgments that disrespect, denigrate, or isolate older people. That's the bad kind. But there's also ageist self-stereotyping, where an older patient might say, oh, I'm just too old, I can't do that. That might be based on misunderstandings. There's positive ageism, Medicare and Social Security. And then there's beneficent ageism, which is, oh, I'll just take care of this poor old person and make all their decisions for them. That one is wrong, but it's not against justice, it's against autonomy. So, is there negative ageism in oncology? This is a very interesting study of 197 oncology professionals. They were given Kogan's Old People Scale. Sorry for the name, but it's a well-used scale. A lower score is more negative, and the neutral score is 101, and the mean score among these oncology professionals was 81. In other words, a negative view of older adults. No difference between being a doctor, a nurse, or a rad onc, no difference by age. So yes, there's some evidence of negative ageism in oncology. Now, that same SWOG study was interesting. Age was a factor in whether the trial was discussed, and it was a factor in whether or not the patient enrolled. So you might say, oh, was that ageism? But then they asked the investigators, why didn't you discuss the trial? And they said, because of lack of evidence about toxicity and efficacy. So, of course, a trial is supposed to provide that. So is that ageism, implicit bias, or is it just lack of evidence? Hard to know. There's subtle ageism. I'm particularly concerned about the first kind. There were 40 healthcare workers who were asked to record a podcast on endocrine therapy to a 40-year-old and then to a 70-year-old. And for the 7-year-old, they use elder speak. Short sentences, repeat the information, talk very slowly. And then the people who used elder speak had negative views of ageism on both implicit and explicit ageism. So there's some subtle ageism. The other two are problems with any underserved population. How do we attack these ethical challenges? How do we fix them? For non-maleficence, implement the recommendations of this workshop. We need more evidence. For autonomy, there are lots of suggestions. These are true in other fields, other areas as well. Simpler consent forms, better educational tools, encourage the older adult to talk, get an assistance from a geriatric specialist, hearing and visual assistant devices, remote data collection. That's true for other populations as well. And actually, this Kornblith study, the doctor said, well, I really need extra personnel to come in to talk to the elder patient because it takes more time. I don't know if that's true or not, but that's what the physicians wanted. So combating negative ageism in the culture is very difficult because it's prevalent in Western cultures. This was a study of 704,000 people, 77% of the sample from the US, and across the board, all ages preferred younger people in both explicit and implicit bias test. Just blank. That was the way it was. Changing the culture is very difficult. This particular hashtag I find rather upsetting since I am a boomer. But that is part of the culture that we're going to face with change if we're going to have the justice issue resolved. I really appreciate having been able to do that, this talk this afternoon, and I would very much like to do discussion and questions at the end of all of the other panelists, and we'll be doing it on a panel. Thank you so much for your time.